Hello and welcome to this webinar. I'm Fiona Godlee, Editor-in-Chief on behalf of the BMJ, University of Bristol and the University of Newcastle. I'm really pleased to welcome you to COVID-19 Known Unknowns. This series of webinars stems from an editorial published in the BMJ back in on the 19th of October by George Davey Smith and Marcus Manafo, called COVID-19 Known Unknowns, with the subtitle, "The more certain someone is about COVID-19, the less you should trust them." It was concerned about the polarization of debates and the hardening of positions on key issues, making it hard to make progress in the debate. And it called on us all to move away from certainty and to respect uncertainty. It said acknowledging uncertainty a little more might improve not only the atmosphere of the debate and the science, but also public trust. And that is the spirit of this series of webinars. On November 20th, we had a full day's webinar, an overview of the issues, which is available on the BMJ's YouTube channel. And that's where this session and all the others will be posted. Today's webinar on post-COVID is the 6th in the series of 2-hour webinars. Previous topics have been children and schools, testing in asymptomatic people, vaccines, zero COVID, and new variants. And I'd just like to thank my colleague Cameron Abbasi for chairing the last 2 sessions in my absence. The next webinar in 2 weeks' time will be on, or sorry, I should say on May 13th, I think that's the date, will be on COVID and mental health. Our thanks to Zoom, who have provided the license for this webinar free. And as for this webinar we're about to enjoy, we have over 2,800 of you registered to join from all over the world, which is a fantastic number. We aim to look at key aspects of this fascinating and very troubling phenomenon. What is long COVID or post-COVID? What good data do we have and from which parts of the world? And what do we know about the prognosis and available approaches to treatment and rehabilitation? We've got some great speakers. The timing is going to be very tight and we want this to be as interactive as possible. So if you could post any questions via the Q&A function, and we will try to put as many of these as possible to the speakers after each session and in the discussion at the end, which will be chaired by Phil Hammond. Please also tweet using the hashtag COVIDunknowns. So we've got a lot to get through. I'm going to hand straight on to the first session, which is about what do we mean by long COVID and post-COVID, chaired by George Davey Smith.
Thanks, Fiona. So for this first session, I'm pleased to introduce as the first speaker, Elaine Maxwell, who is the author of 2 NIHR reviews of enduring COVID symptoms and a knowledge broker for NIHR. So I'll hand over to Elaine.
Just sharing my slides. Thank you, George. So I'm going to talk about the evidence that we reviewed in our 2 reviews about what is long COVID or post-COVID. And one of the challenges is that the definition of the phenomenon is still quite fuzzy, and that makes it difficult to research. So different terms are used both in the UK and internationally. And NICE in December identified a post-COVID syndrome, but they didn't specify what the symptoms might be. Long COVID is a term coined by people with lived experience, and that allowed them to challenge some of the initial assumptions that healthcare professionals and researchers had. Patient-led research has identified 205 different symptoms, so that's a very heterogeneous group of people. And we have this tension currently between keeping a definition open enough to absorb new findings as they emerge versus the need for a bounded definition for research and to identify and treat different symptom clusters or syndromes. Trying to make sense of the evidence that has been published is hampered by the fact that they all use different case definitions and different time points. Often long COVID is described as somebody reporting at least one of a long list of symptoms, but they don't all have the same symptom. And the requirement for laboratory confirmation of COVID-19 varies. Much of what has been published, not all, but much of it is descriptive and it's cross-sectional. And it focuses on people who've been in hospital and the biomedical consequences, and less is known about the social and psychological consequences which the patient groups tell us are very severe for some people. It is clear that a significant number of people have enduring symptoms, and for some of them it really interferes with their day-to-day life. It doesn't appear to be related to respiratory symptoms from a COVID-19 infection. So there are some people with long COVID who only had loss of taste and smell. And a number of studies have shown that people with a history of COVID-19 are more likely than control groups to report symptoms 3 months or more later. One of the things that we identified in both our themed reviews is that seldom heard groups are rarely seen in the prevalence data, and also that cross-sectional surveys may miss the corona coaster, the remitting and relapsing cycle that a lot of people with long COVID report. And despite this, there's still very variable prevalence estimates. So the ONS has the largest data set in the UK, and I know that Ben and Dan are going to be talking about that later, so I'll leave that to them. But just a note on the 70,000 people who still had symptoms at 12 months. Given that last February, relatively few people in the UK had a COVID infection, it'll be really interesting to see how this figure increases over the next 9 months as the infections from wave 1 and wave 2 start to mature. Studies of people reporting symptoms 6 months after hospital discharge vary from 47% to 76%. And one study in the USA reported that 30% of people who had not been to hospital were still symptomatic at 6 months. The prevalence does seem to be higher in people who've been in hospital, but the incidence is higher in community cases, because in the UK, there's a 10-fold difference between people who've tested positive for COVID and people who've been admitted to hospital. So we don't know what causes long COVID, but there are some data that suggest some plausible propositions about what might be causing it. Now, any of these things might be independent or they might be interdependent, and some people have more than one of these at the same time. So there are definitely some people who've got post-viral fatigue that resolves by 3 months. And there are definitely some people who meet the criteria for chronic fatigue syndrome, and we've seen that with previous SARS epidemics. We don't know a lot about chronic fatigue syndrome, and in fact, this has shone a light on that. But it's too early to say that everybody who's got long COVID has got chronic fatigue syndrome. We know that some people who've been critically ill exhibit symptoms that are very similar to long COVID. So post-ITU syndrome is well described, with a third of people who've been ventilated and up to half of people who are there for over a week developing ICU-acquired muscle weakness. And many of them then develop cognitive dysfunction and insomnia and PTSD. And many of them, their admission isn't related to any virus. We know from the data that people who are discharged from hospital having had a COVID infection have higher rates of multi-organ damage than control groups. But we also know from the CoverStan study that low-risk people who were not admitted to hospital also show organ damage after a COVID infection. And there's a small study from France that looked at people with symptoms lasting more than 3 weeks, compared them with control group, and found brain biomarkers that are associated with cognitive impairment and autonomic dysfunction. We also know from the data that people discharged from hospital can have high levels of D-dimers for some time afterwards. And an Italian study reported that 17% of their patients exceeded the threshold for pulmonary embolism 3 months after discharge. So there is a discussion in the literature about whether microvascular injury is the cause of persistent lung problems in people with enduring symptoms. We also know that people who've had COVID-19 have raised inflammatory markers, and some studies have correlated that with organ damage and also symptoms like reduced exercise tolerance. But people who've had an asymptomatic or a very mild infection are seen to have markers related to mitochondrial stress 8 weeks after the initial infection. And some people who've had COVID have altered gut microbiome, and that's correlated with inflammatory markers. And some of the people with long COVID have symptoms that are very consistent with autonomic instability that may well be immune mediated. We also know that there are a significant number of people who still test positive for COVID-19 for quite a long time, even though they may not have symptoms of it. and that has led some to suggest that viral persistence may trigger a late onset immune response that explains long COVID symptoms. So this wide range of potential pathology plus the very wide range of symptoms means that it's really hard to identify what the risk factors are. And we're probably going to have to divide long COVID into more homogeneous subdivisions to really understand the risk. However, at a global level, it does seem that symptoms are more commonly reported by women, and some have said this may be due to different T-cell responses that are seen in other conditions that are more common in women. People of working age are more likely to report symptoms, and the risk of readmission has been found to be greater for people under 70. But it's important to recognise that long COVID has been reported in all age groups. The data around ethnicity is a bit less clear. Both the FOSP study and ONS report a higher prevalence in white ethnicity groups, but readmission seems to be more likely in minority ethnic groups. And I think this just illustrates the difficulty about using an umbrella term and then trying to identify risks. Unsurprisingly, perhaps social deprivation and pre-existing ill health correlated with reporting symptoms. The real conundrum, though, is an understanding of what the relationship of the initial infection and treatment for that is to development of long COVID. Whilst people who've been in hospital do report more long COVID, follow-up studies haven't been able to associate it with the level of intervention in hospital. And the FOSP study found that treatment with steroids in hospital wasn't associated with recovery. So I think at this point, all we can really say is that we have moved from some of the unknown unknowns to understanding some of the known unknowns, and quite a lot more research is needed. Thank you.
Great. Thanks very much, Elaine. So I'm now going to hand over to Joe House. Joe is a reader in environmental science and policy in the University of Bristol and is speaking here as a long COVID patient.
Hello, everyone, and thanks for all those attending today. I'm going to start with an apology, actually, because I'll probably forget to say things I wanted to say. I'll stumble and I won't be able to find words. I might yawn excessively, especially by the time we get to panel. In normal life, I'm a University of Bristol lecturer, and giving talks is my bread and butter and actually my passion as well. But now it takes a lot of effort. It takes me at least 4 times as long to do anything cognitively as it did before, and I'll have to have a lie down, and sometimes I can't do anything. In fact, in order to give this talk, I've got my fellow long COVID sufferer, Nikki Smith, who's going to join the panel later as my backup, because from day to day, I can't tell if I can show up to do something like this. So this is my reality. This is the reality for 1.1 million people in the UK right now, according to ONS. I can't speak for 1.1 million people in the UK and more worldwide, but I do hope to share some of our experience from some of the many support groups that I belong to. And thanks to Monique and Paulina for the illustrations too. So there's many people with long COVID, and I just gave a little bit of an insight into me, but my husband and I both have long COVID for a year now. I used to love to cold water swim and dance, and now I have a heart condition and arthritis. I get short of breath. I can't even always make it up the stairs in one go. We have 2 sons, one with multiple medical conditions. But now, instead of us being his carer, him and my other son are our carers. They could tell you about Sophie, a young nurse and midwife who's still having high temperatures a year later every day, and there is no long COVID clinic in her area for her to go to. Karen, a hospital pharmacist who tried multiple times to go back to work and has now at 12 months just had to stop work and been diagnosed with multiple clots all over her body. A friend Lou, who's a single mother of an autistic child and used to run a parent carer support group that I was part of, and now she needed to use a mobility scooter to leave the house. and everything tastes disgusting to her, even water from the tap. Or Sammy, a midwife and wellbeing coach, her and her daughter both have long COVID and struggle to walk great distances or manage schoolwork. So there's a lot of us ill out there, and we're all different. We all need individual treatment, but we also need holistic treatment that takes account of everything that's going on for each one of us, and that's very complicated. But there are some real barriers that we're finding to get the treatment that we need. The main barrier is actually being believed. Now, these were quotes I took for when I talked at the NIHR webinar 6 months ago when we brought out the first report. And I'd like to be able to come here today and say this is different, but actually these comments are all still relevant to what people say today. And I'm just going to give you a few seconds to read. So the problems about being believed happen at all levels, at GP level, when we end up in A&E, when we have to call ambulances, even when we get into clinics, from family, from friends, from employers. Things have got better with the NICE guidelines and more in the newspapers and the media, and that's really helped. But the reality is there's still many barriers for us to access treatment. This was a survey that was carried out by the Long COVID Support Group, and you can find more details of it on the website. 74% of people currently are struggling to access these long COVID clinics that have been set up and that were announced last year. Of the 286 survey respondents, 181 have been refused referral by the GP because of not being believed, because of lack of positive tests, which has been a real barrier and continues to be. And many of us in the first wave, particularly, there were not available tests unless we were hospitalized. It's been great that clinics have opened, but already some have even had to close temporarily because they're oversubscribed or because the hospital's under other pressures. People are told, oh, you've not been ill for 12 weeks yet, when actually the NICE guidelines say we can be referred from 4 weeks. And other people have been told, oh, but you were ill with COVID ages ago, you can't possibly still be that. Some may even get refused when they get to the clinic, or there's not clinics in the area. But of those who were referred successfully since 18th of December, about half have actually been seen face-to-face or on telephone, although some are only getting questionnaires and then referred to the Your COVID Recovery website, which is not really the care we need or the level of detail and support. So what do we need? We need recognition of the number of us. We need research, and we need rehabilitation, many of us having been ill for such a long time. So what are some of the barriers to that? Partly knowing what sort of support we need and what is available. That's quite hard for us to tell as patients. The pathways, the medical pathways can be quite complicated, and often the doctors don't know the medical pathways for referral to long COVID clinics, for example. There's very long waiting times and lack of services. There were anyway before the pandemic, but that's obviously exacerbated with the pandemic. And with the long COVID clinics, some people are being told they won't get seen till next year. So it was great that there was 10 million announced last financial year for long COVID clinics. But when you think that there's 1.1 million people with long COVID, that's obviously less than £10 per person. And new funding of 24 million has just been made, but that's still really not going to hit the vast expense to the NHS, and also the loss of income and the loss of workforce and the loss of taxes there are. And I would just say that also a lot of the people who are ill with long COVID are medical and healthcare professionals themselves. So that puts further strain on services. Often we're excluded for the full range of conditions we have. So you might actually be sent to respiratory, or there might be a focus on respiratory, or there might be a focus on physio, but not the full range of conditions and symptoms. And it's very difficult for a lot of marginalized groups. Elaine talked about, the prevalence in ethnic minorities and the prevalence in children. But parents of children with long COVID have been finding it particularly hard to get access to care and support and for it to be acknowledged. We might face stigma and peer pressure to go back to work, and financial pressure to go back to work. And many of us have tried to work through, been back to work, crashed out again. And because pushing ourselves before we recovered sends us to bed and takes us back a huge step. The issue about excluding non-tested people from accessing medical support and clinics, but also in a lot of the research that's been funded, what we're seeing is people will only do research on people when they've got a positive test. And the trouble with that is it misses out all of those of us in the first wave in March who are very ill and weren't tested, but have been diagnosed by clinical conditions and circumstance. And that's a whole 6 months of long-term data that's not being collected and research that's not being done. And on top of all that, we're ill, and it's really difficult to do things and cope with all of this when you're ill and you've got brain fog and you're absolutely exhausted. This data, Elaine mentioned about the impact on different aspects of our life. And this data is from an NIHR survey, but it chimes with the ONS data and some other recent publications that have come from patient groups as well. It's having a massive effect on our family lives. Many of us are carers who can't care anymore. Many of us are not back in work at all, or only able to work part-time, or have lost our jobs because we're not able to do it and we've had to be replaced. And the costs of being ill, as well as losing income and all these different treatments and supplements and everything we're desperately trying, all adds up. I think what we look for is really to have some kind of support. If we had better support to stay off of work and to actually be able to recover, it would be less of a long-term burden. Something like a furlough scheme, but for the ill, so we can get better, fully recover and get back into work. The whole system as well for going back into work and then this is true in the university, and lots of the long COVID medical people have told me this. The model is that you go back when you can work 50% time and be full-time within 2 months, and that's not something most of us can manage. So we need help from unions and care workers, citizens advice, and just think that when the rest of you come out of lockdown, we will still be in our bedrooms. Those of us not hospitalised, this wasn't a mild disease. Many of us were terrified. Many of us wrote wills and wrote letters to our children. We've been ill for a long time, and 12 months for treatment is not just. Even waiting 12 weeks being very ill is unjust. So we need early support to avoid the long-term problems. There's a lot of mental health problems associated with being chronically ill and having been scared and been very ill, and not being able to access help, and not being able to plan for the future. But our anxiety isn't causing our illness. It is the other way around, and we need help for both. We'd like better information about how to get better for those of us who have exercise intolerance. We can't do the graded exercise therapy. We have to take things carefully. We might have heart conditions that we do or don't know about. So we need some really careful support around paced, individualized rehabilitation. And it would be great if we had guidance for medics and schools and employers so that they understood what's going on with us better. Finally, I'd like to come back to this comment that was in the NIHR report. NIHR called us experts by experience. We're not well people, but many of us are professionals and people from all walks of life, and we're fighting hard and we know what's going on. And over the year, we've been supporting each other and we've built up a lot of knowledge about what's going on and what can help us. So we'd like to see ourselves included. We need policy in health and social care. We need employment and financial support to make us better, but we want to be engaged with that policy and that planning. This is a new disease and it's emerging, and we are living through it, and we have gained a lot of expertise. So what I'd like to say to you is please work with us and think about how we can work with you to best share our learning. I'm a member of loads of groups, some of which are mentioned here, but the COVID-19 research Facebook group is one where researchers can engage with people with long COVID, and anyone's welcome to join. Thank you very much.
Thanks very much, Jo. That really puts into perspective what we're talking about here this evening. The last speaker on this session is science journalist Laura Spinney, who wrote an excellent book about the 1918 influenza pandemic, Pale Rider, and Laura will give some historical perspectives on the current situation.
Thanks very much, George. So I'm also going to start with an apology, just to say that unfortunately I have to leave soon after this. So I'm sorry if I'm not able to answer any questions. As I understand it, this webinar is about unknowns, uncertainty, and history offers plenty of that. And just to give you a startling example to start with, the so-called Russian flu, which was the pandemic that preceded the so-called Spanish flu of 1918. So the Russian flu happened in the 1890s and is estimated to have killed 1 million people. It's now, there's now a theory that is being taken quite seriously, that it wasn't a flu at all, but it was caused by a coronavirus, one of the 4 that now causes the common cold and may have spilled over and caused that pandemic at that time. In which case, mainly it has to be said, anecdotal documentation of a wave of nervous disorders that followed in the wake of the respiratory symptoms becomes interesting from a comparative point of view with long COVID. There isn't a great deal of data about them, that's the problem, but there is, for example, speculation that it might have inspired Edvard Munch when he painted The Scream. So moving on to the 1918 flu, the so-called Spanish flu, the suspicion that it was a chronic disease came about already in the 1920s, as soon as it was over, essentially. And it was very clear that both the disease itself and the longer term, the acute disease and the chronic symptoms affected every organ in the body. It was very multifarious, those symptoms, as with COVID. So just to give a sample of the sort of symptoms that were documented, there was fatigue, lethargy. It was blamed, for example, for causing a wave of lethargy in Tanzania in 1918, which meant that people were unable to, an already depleted population was unable to plant when the rains came at 1918, and it's been blamed then for triggering the worst famine in a century in that country, the so-called famine of Corms. There was depression, psychoses. There were studies conducted, for example, at the Boston Psychopathic Hospital, where people were so-called recovered flu patients were diagnosed with dementia praecox, which is, as you probably know, an obsolete name for schizophrenia. But those people mainly recovered within 5 years, a long time, but still they did recover, whereas dementia praecox was considered incurable. So there was a discussion at the time as to whether a new label was required for this flu-triggered syndrome. There were also cases of auditory hallucinations, visual hallucinations, heart conditions, breathlessness again. So also very wide ranging. The data, unfortunately, are mainly anecdotal. And there's another major problem when you're thinking about the 1918 flu, which is, of course, that it overlapped with a war. So, for example, if you're thinking about the psychiatric symptoms of that may have been connected to the flu, depression can, we know, be caused by virus traveling up the olfactory nerve, as the flu virus can, and causing inflammation in the brain. But depression can also be a result of bereavement and social upheaval. So that is a big problem whenever you're thinking about the 1918 flu. But because of that, some of the most interesting research comes out of countries that were neutral in the war, meaning that they allow you to disentangle the contributing factors. There is an intriguing study out of Norway, which very frustratingly still hasn't been published. I'm not quite sure why. It wasn't published at the moment when I mentioned it in my book either in 2018. The researcher is a demographer called Sven Erik Mamlund, and he looked at the records of psychiatric asylums in his country between 1872 and 1929. And he found that in each year in that interval, when there was no pandemic, there was a few cases of mental illness related to flu admitted to the asylums in Norway. But in the 6 years following the 1918 flu pandemic, the number of admissions was 7 times higher than the average in non-pandemic years. So this study comes with all sorts of caveats, apart from the fact that it hasn't been peer-reviewed. Notably, it's impossible to know what those people were suffering from. It's even more difficult than impossible to know to link their symptoms to the flu that they suffered previously, for sure. But with all those caveats, Sven Erik Mamlund concludes that they were probably suffering from some kind of post-viral syndrome. And that if that was the case, they were almost certainly the tip of an iceberg, because at that time, most people would not have come forward to report their symptoms. There is one other potential after effect of the 1918 flu, very controversial, which is the subsequent overlapping pandemic of encephalitis lethargica, known colloquially as sleepy sickness, which washed over the world between about 1917 and 1925, peaking in around 1921. It's thought to have affected around 1 million people worldwide. A third of them seem to have recovered, a third of them died, and a third of them went on to develop years later a disease that resembled advanced Parkinson's disease. These are the patients that Oliver Sacks described in his best-selling book, Awakenings, who were helped eventually by the Parkinson's drug L-Dopa, but only temporarily. And the thing about encephalitis lethargica is that the debate as to whether it was linked with the 1918 flu started in the 1920s is still not resolved, because nobody has ever found viral RNA in the brains of encephalitis lethargica patients at post-mortem. Doesn't mean it's not there, perhaps the techniques aren't sensitive enough. But for the moment, the jury is out. There is a theory, however, that is being investigated at the moment, and that some people are thinking long COVID might help with, that an infection, including a respiratory infection, can trigger perhaps a brain disease in people who were somehow predisposed genetically. So that's a possibility that the 1918 flu opens up to investigation, but of course we have to be incredibly careful. Different diseases, different contexts, different viruses belonging to different families. So thank you very much.
Thanks very much, Laura. And that was a great first session. I'm going to hand straight over, in the interest of time, to Fiona Godlee, who is going to chair the next session.
Thanks very much, George, and thanks so much to the speakers in that first session. This next session is about international experience, and in particular, what and where are good data available about long COVID or post-COVID. And we have three excellent speakers. The first of a pair of speakers, we have Ben Humberstone and Daniel Ayoubkhani from the Office of National Statistics in the UK. Over to you both.
Thanks, Fiona. I'll just attempt to share my screen. And hopefully you can see that. So what we're going to present here are the results of two studies that we've done. The first of which looks at, follows up a self-reported long COVID on the basis of a social survey of around about 400,000 respondents who we follow up weekly to begin with and then monthly for a period of 12 months and gather information about their experience. This has been driven by some of the discussions that we've had with colleagues and patient groups and others to try and find out what the lived experience of long COVID is like, and try and calculate the prevalence so that we understand what the impact on the economy and individuals' lives, their ability to do the things that they would normally do, as so well described by Joe earlier. And then I'll hand over to Dan, who will cover our study on multi-organ impairment post hospitalization. So, don't know if that's moved on.
Yes, I think it has. Yep.
Okay, great stuff. So our estimated.
Sorry, Ben. Do you want to put it on presentation view? Is that possible?
It certainly is. Apologies for that.
Sorry. I think it was that one, yeah. That doesn't matter.
I say it's possible.
Don't worry, it's fine.
Apologies for this. I've got it beautifully on the screen in front of me, which is always, if I try again, apologies. So what we'll be talking about is the prevalence. That's no better, is it?
Doesn't matter, Ben. Honestly, it's very good.
Okay.
You're doing
Thank
great.
you. That's very kind of you, Fiona. So estimated prevalence we've got at 1.1 million. That's self-reported long COVID. That's irrespective of tests. That's people's experience of long COVID. Around 700,000 had symptoms for at least 12 weeks. 70,000 of those have had symptoms for at least 12 months. So these are large numbers of people who are experiencing symptoms for a long time. When we looked at, we also asked a question about the impact on day-to-day lives, the activity limitation, including, so did you have no activity limitation? Was your activity limited a little or a lot? And we found that 200,000 actually had that their activity was limited a lot. So that meant they weren't able to do day-to-day activities, the types of things that we take for granted. About 1.7% of the total population of the UK have got some form of long COVID, self-defined or self-reported. Of those, it's about 2.5% at ages between 35 and 69. So that's a large proportion of the working age population. So that gives an indication of the type of impact that this is going to have on the economy as we move forward. So getting a really good understanding of this is so important. I shall move on now to the percentage of study participants reporting any of 12 symptoms. So we picked the 12 most frequently observed symptoms and looked at around 22,000 individuals who had had a positive COVID test. We then looked at a control group of the population who were matched on age and sex, to see whether they had had any of the symptoms that we were talking about, to see what the prevalence of those symptoms was like in the general population. And the prevalence amongst those who had had COVID and were moving into long COVID with symptoms of more than 12 weeks, the numbers were 8 times higher. So there's something quite significant going on there. I'll now hand over to Dan for the multi-organ impairment.
Thanks, Ben. Hopefully you can hear me okay. So this in this part of the study, or it's a separate study, we worked with colleagues at University of Leicester, at UCL, and NHS Digital to investigate post-discharge complications amongst 48,000 patients who were hospitalised with COVID-19 using electronic health records from all NHS patients and GP surgeries in England until the end of September last year. And this study was published in the BMJ just 2 weeks ago. So over a mean follow-up time of 140 days, nearly 1 in 3 patients were readmitted hospital. More than 1 in 10 patients died after discharge. Post-discharge diagnosis rates were greatest for diabetes, major adverse cardiovascular events, both at around 130 events per 1,000 patient years. And to explore how these rates compared to what we might expect to observe in the general population, we one-to-one matched our 48,000 COVID-19 patients to controls on the basis of demographic and clinical characteristics, using 10 years of health records across nearly 50 million NHS patients. So compared with individuals in the general population, discharged COVID-19 patients experienced elevated rates of diabetes, cardiovascular disease, kidney disease, and liver disease. And in particular, we can see the rate of cardiovascular events was around 3 times higher in COVID-19 patients than in matched controls. And crucially, the rates of all these adverse events remained elevated when considering only incident cases, as shown by the chart on the right, where we exclude anyone with a history of these conditions from the analysis. These results demonstrate that individuals discharged from hospital after COVID-19 face higher rates of multi-organ extrapulmonary dysfunction compared with the expected risk in the general population. While the results don't confirm the presence of a causal relationship between COVID-19 and subsequent morbidity, they do suggest a statistical correlation that warrants further investigation. And our findings suggest that the diagnosis, treatment, and prevention of post-COVID syndrome requires integrated rather than organ-specific approaches. Next slide, please, Ben. So what are the known unknowns, at least from our perspective as statisticians with an interest in public health and the possible consequences for socioeconomic inequalities? So in terms of population prevalence of subacute symptoms, it's not clear how the vast number of people reporting symptoms on our survey will translate to clinical diagnoses and referrals. We also found that around 2/3 of people self-reporting long COVID said that their symptoms are having an adverse effect on their day-to-day activities. And clearly these are the people who are most likely to present in primary care. However, it's not yet clear which symptoms or groups of symptoms are most highly correlated with activity limitation. Knowing this can inform the treatment pathways being offered to patients, and it's something we're currently working on. In terms of post-COVID organ impairment, a number of studies, ours included, have recently been published with a focus on patients hospitalized at the acute phase of infection. However, organ dysfunction in non-hospitalized individuals has been far less well characterized. Several small-scale studies have demonstrated multi-organ involvement and mild impairment in low-risk individuals, but further research is needed to understand the instance at a population level. We're attempting to do this by linking COVID-19 infection survey participants to hospital and primary care records. Recent studies of hospital patients have shown that risk factors for prolonged symptoms include middle age, female sex, and comorbidities, although the overall the evidence is mixed, and risk factor studies outside of hospital settings remain scarce. As the disease etiology is uncertain, so too are the risk factors, particularly for long-term consequences. And finally, the potential socioeconomic burden of long COVID is clearly huge. We know that early attempts have been made to quantify this, but it's not going to be possible with any level of precision without reliable population-level estimates of the impact on work, education, and health and social care needs. Thanks very much.
Thank you so much, Ben and Dan. That was a tour de force. I'm going to go straight on to our next speaker in the hopes that we can pull all this together in the discussion at the end of the total webinar. Time is tight, as I mentioned earlier. So if I move on now to our second speaker, Simone Benatt, who is from the Division of Infectious Diseases at the Ospedale Papa Giovanni in Bergamo in Italy. Over to you, Simone.
Hi, good evening to everybody. Let me share the screen. And can you see it properly? Hope so. Good evening, and thanks to you for your invitation. My name is Simone Benatt, and I am an ID specialist.
Simone, we haven't got your slides up just yet.
Okay.
Let's try one more time.
Like this. Is it better?
No, we might ask. I wonder if Nikki or someone backstage, so to speak, could, because I think you've got the slides there, have you, Nikki? Sorry, Simone.
Okay, sorry, no, it's my fault. I'm sorry.
No,
Can you see it here now?
Right, we have it. On you go.
Okay, you have it.
We can see it now, yeah.
Okay, so, and you see it in presentation view. Yeah. Anyway, I don't have any sort of financial relationship to disclose, but I admit to believe in the existence of some COVID-related long-lasting condition, not just explained by psychological or environmental circumstances. In the last January, I co-authored this small paper with a lot of people. I'm talking on behalf of all of them. We are based in Bergamo, which is a small, lovely town in the north of Italy. As you may know, Lombardia was one of the hardest regions in Italy to be struck by COVID epidemic, and notably, it was the first region of the westernized world to have this problem. And in the first wave of the epidemic, we recorded in excess of 5,000 deaths compared to the previous year. So in the wake of this disaster, we struggled to prepare an intervention and for survivors. And our aim at that point was mainly to assess for post-chronic illness, disease, and traumatic stress disorder. In that time, we didn't even suspect the existence of long COVID. So what we did, we contacted personally by means of administrative people in our hospital, all the people who had been in contact with our hospital, admitted or discharged from the emergency room. And we wanted all of them to come in person and be seen personally by our doctors. So it was quite exhaustive, and we arranged with the help with the caregivers to be able that everybody was actually coming. But it is a population very concentrated on the hospitalization stages. This is an overview of what we did. As you see, there was a nurse-led and psychological and physical therapist evaluation and an infectious diseases consultation. And after that, if any other investigation was needed, at that point, it was done. This is the cascade of enrollment. And what I want to underline here is that from 2,600 people eligible for this intervention, at the end of the day, just 57% of them actually was enrolled in our study. And the population is a population of prevalently male and elderly subjects. So it reflects quite strictly the epidemiology of severe COVID pneumonia. As we can see also, if we look at the maximal oxygen requirement during the episode, just 30% of the people were not admitted, and it was the ones who didn't need oxygen and were breathing room air. But how representative is this sample to the population of all SARS-CoV-2 infected people? This is a key issue, and we can try to depict the representativeness of our sample if we go to the excess of deaths recorded and the estimated case fatality ratio of this population. And we can see that our sample is not at all representative, because 1,500 people are just about the 2% of the people infected by SARS-CoV-2 in our province. So we have to take this clearly in mind when we talk about the results of our study. Also, the timeline is very important. If we consider 84 days as the definition of possible post-COVID syndrome for the NICE guidelines in December have been suggested, and we see that more or less our patients were seen at about 135 days after the onset. But if even some of the patients that were qualified as recovered, had they have been seen earlier, we probably would have classified them as people with the symptoms, persisting symptoms. How did we assess the symptoms? It was a physician questioning on a specified symptom list, But the final question, and this is very important, was always, has the patient recovered, yes or not? I think that it is very important to rely on semi-quantitative scales. This is very useful because it helps the objectivity of the examination, but it is not just enough, this. The idea behind semi-quantitative scale is that of a minimal interaction principles, but symptoms need to be explained together with the patient. We need to, the history taking is a two-way discourse. We cannot just fill in scores. And this is probably some of the problems we have while we rely just on symptoms list to assess those patients. We have many biases, and the most important is a recency bias, according to me. The fact that a patient, when talking about his current status, is not talking about what he had in the last weeks, probably is referring to the last few days. And we know that long COVID is a fluctuating illness. So this is something that has to be captured very quickly, very carefully by our interview. So sad, 1,191 patients, 76% of them seen at more than 84 days from the onset of disease. So the potential post-COVIDers, 39% of them were not recovered, were considered not recovering. I don't have a fine-tuning statistical analysis, but by simple tests, we can say that the majority of them were female. The age is not a big distinction among the two groups. And also it makes not a big distinction the fact of having being admitted to hospital. But if we stratify the two groups according to the severity as estimated by the oxygen requirement, we see that a big part of those patients actually probably suffer from post-intensive care unit disease, because there is a significant difference among the recovered and post-COVID syndrome. In the latter group, we have more patients who stayed in the ICU. Another point I would like to underline is the role of the instrumental tests, because we always look for instrumental tests to substantiate an impression, which comes from the history taking, but we use them in a, should I say, off-label way. We do not have any validation of those tests, so we cannot really rely on them completely. If we look to the dyspnea, dyspnea was complained by 20% of the sample of our cohort. But if we look to the MRC, which is the scale we used for assessment of the dyspnea, and if we look to the DLCO reduction, which is the reduction of the transfer of the carbon monoxide across the lung interstitium, we see that the agreement among those three variables is very low, is miserable. So we have to do something more, and we probably, we suggest we have to study different cutoffs, because those instrumental tests have been studies for have been taken as such from studies from lung physiology and other diseases. So they probably need to be adapted to this particular situation, which has, of course, still to be defined. So my conclusions, both hospital-centered and larger population studies likely suffer from information and selection biases. And reported symptoms most often self-improve a long time, so the moment of assessment is crucial. Semi-quantitative quantitative tools and instrumental tests can be misleading, especially because we do not have any pre-COVID reference and because we use off-label cutoffs. And we need to be aware of the convergence and interaction of different conditions, as it has been said just before. The knowns, post-COVID is a mix of different interplaying conditions, and I don't know how to better separate from each other. Self-improvement is slow, but it occurs, and we should ask ourselves to what extent does it occur and what predicts such improvement. We need to train our diagnostic tools, and we probably need to study them, their cutoffs in a different way. And also, I think that it is very important to capture this day-to-day fluctuation of symptoms, because this is probably indicating a mechanism which is specific of this condition. We need, of course, objective biomarkers because the symptoms cannot be a gold standard for definition of this condition. And after that, I just want to acknowledge the work and the collaboration of this large group of colleagues. And I want to tell you that our project is ongoing and open to any kind of collaboration and suggestion. And I thank you very much.
Simone, thank you so much for that. Very, very impressive rundown of a great deal of work with lots of questions remaining. Thank you very much. I'm going to hand on to our third speaker. Then we have Maxime Taquet, who is from the Department of Psychiatry at the University of Oxford and also affiliated with Harvard Medical School. And Simone just needs to stop sharing your screen. Over to you, Maxime.
Brilliant. I hope you can see that. Let me put that in full screen. Yep, can we see the slides?
Oh, now you know how to do that. You need to tell us all how to do that, but I'll leave you to carry on.
Okay, so hi everyone. Very glad to be here. I'm going to speak to you about a study that we've published in the Lancet Psychiatry 2 weeks ago, where we looked at the outcomes at 6 months in terms of mental health and neurological health in patients who had a diagnosis of COVID. So there were 3 questions really that we tried to answer with this study. The first one is how common are neurological and psychiatric disorders in the 6 months after a COVID-19 infection? And we looked specifically at 14 individual diagnoses, and those included things like stroke, which is a blood clot that reaches the brain, brain hemorrhage, dementia, Parkinsonism, as well as psychosis, anxiety, and depression. And then the second question that we asked was whether the severity of COVID-19 illness affects how common those diagnoses are. And so by severity, what we mean and what we used as, I guess, severity factors was whether a patient with COVID-19 had to be admitted to a hospital. If so, whether they were admitted to an intensive care unit, and whether they had encephalopathy, which means that there is evidence of their brain being involved as part of the acute illness. And then the third question was whether the outcome were more common, the sort of neurological and psychiatric disorders were more common after a diagnosis of COVID compared to other infections. So we used influenza and other respiratory tract infection as control cohorts. So how did we do the study? Well, we used data from a large electronic health record network, mostly in the US, of 81 million patients, accessed via the Trinetics platform. And we measured the incidence of each diagnosis in the 6 months after the COVID diagnosis, and we compared with matched cohort, which means that at baseline, that is before either they had the flu or COVID, the cohorts were relatively similar in terms of their age, their race, their sex, and their comorbidities and the general health. So this is the numbers that we had in terms of patients with COVID. So just over 235,000 of them had diagnosis of COVID. So that's out of the 81 million that we had access to. And 190,000 of them were not hospitalized. So we took them to be the, I guess, least severely affected patients, whereas 46,000 were hospitalized. And then about 9,000 of them had to be admitted to an intensive care unit, and 6,000 of them had encephalopathy, so evidence of brain involvement. And then for comparison with COVID-19 cohort, with the influenza cohort, we had just over 100,000 patients in each cohort. And for comparison with the other respiratory tract infection, we again had just over 230,000 patients. So what were the main findings from this study? Well, the main finding was that about 1 in 3 patients in the 6 months after the COVID-19 illness go on to have either a psychiatric or neurological disorder. Because most patients were not hospitalized, the rate in the non-hospitalized patients is about the same. So 1 in 3 patients non-hospitalized, just under that, had either a neurological or psychiatric disorder. But then, as you can see on the slide, the rate increases quite dramatically as you move towards the most severely affected patients. So if we look at the patients who had to go to an ITU unit or receiving intensive care, almost 1 in 2 patients had one of those disorders in the 6 months. And if we look at the patient with encephalopathy, almost 2/3 of the patients had evidence of neurological or psychiatric disorders. And then we also looked at patients in whom this was the first ever either neurological or psychiatric diagnosis. And this is the second line on this slide, where you see that about 1 in 8 patients go on to have a first neurological or psychiatric diagnosis. So what that means is those patients had no psychiatric or neurological diagnosis in the past, as far as we knew from their health records. And again, this increases to 1 in 3 patients if you look at the most severely affected patients. So in terms of the specific diagnosis, I'm only presenting a subset of those on this slide. The bulk of the 1 in 3 patients are suffering with anxiety and depression, which account for 1 in 6 and 1 in 7 patients overall. And actually that rate increases somewhat, but not dramatically if you look at the most severely affected patients. So it only increases, so to speak, to 1 in 5 if you look at patients with encephalopathy. And actually, if you, in our data set, at least, if you look at patients who required intensive care unit treatment, the rates were very similar to the rates that we've seen in all patients with COVID-19. So what that means is that according to that data, at least in that population, the rate of anxiety disorder and mood disorder, which is largely depression, are affecting all patients across the level of severity of the COVID-19 illness. This is in sharp contrast with the other 4 diagnoses that I'm presenting on this slide, which are all much rarer, affecting only 1 in 70 or 1 in 50 patients. But those increase quite dramatically if you look at the most severely affected patient with COVID. So if you take stroke, for instance, as an example, 1 in 50 of them go on to have 1 in 50 patients who had a diagnosis of COVID go on to have a stroke in the 6 months after their illness. But that increases to 1 in 11 if you look at patients who had encephalopathy. And psychosis, which is another psychiatric disorder, which presents in people having delusions, which is believing in things that aren't real, or hallucination, which is sort of hearing usually or seeing sometimes things that aren't real. That also sort of affects only 1 in 70 patients after COVID, but that increases to 1 in 14 if we look at patients who had encephalopathy as part of the acute COVID illness. Now, how does that compare to other health events? So what you see here, for those who know that type of curves, those are Kaplan-Meier curves. So what they look at is the number of people affected by those different disorders as we follow them up for from 0 to 180 days. And you see the rates obviously increasing because this is the cumulative rate. But what you mostly see is the contrast between the patient with COVID in red compared to the patient with another respiratory tract infection in blue. And you see that the rates are quite dramatically increased compared to the patient with other respiratory tract infections. And this is the same slide, but showing the results for the comparison with influenza, where we also see a large contrast between the 2 groups. And overall, the rate of any neurological or psychiatric diagnosis is about 44% more likely in relative terms after COVID than after influenza, and about 16% more likely than after other respiratory tract infections, which is something that we can discuss later. It shows that there is there seems to be something specific about COVID-19, but equally, it doesn't seem that this is 10 times more likely after COVID-19 compared to, say, influenza or the respiratory tract infection. Potentially important negative findings were findings about Parkinsonism and Guillain-Barré syndrome. And the reason why we looked at those is that they have been in the past related to viral illnesses. And so we wanted to see whether there was a signal for an increased rate of those disorders after COVID-19. Parkinsonism, for instance, occurred in the 1918 pandemic of the flu. And so that was the reason why we looked at that one. Guillain-Barré syndrome occurs after a wealth of viral infection, and it didn't seem to occur more often after COVID than after the other respiratory tract infections. Even though we need more follow-up to make sure that there is no signal at all, those are at least somewhat reassuring. So what are the limitations of this study? Well, there's plenty, and it's important to keep them in mind when we interpret the findings. It's a large data set, which is great. It gives us some power to detect even rarer events. but they are routine healthcare data, not research data. What that means is that some diagnoses may be missing or incorrect. When somebody goes and see the GP might make a mistake in the first place, and then sort of revise the diagnosis later on when they see you for the second time a few weeks later. And obviously that would be reflected in the data set that we have. The results may not apply to people who had COVID-19 but were not diagnosed, because obviously we would not know anything about those patients, because that would not be reflected in the health records. Patients who had COVID-19 might be more likely to have follow-up, medical follow-up or seek medical attention after COVID-19. And that means that perhaps some of the diagnoses that we've picked up as being more likely after COVID than after influenza are just related to the fact that those patients just sought more medical attention. And this potentially might affect things like dementia. And so that's why we're very careful about the interpretation of that particular finding, but all findings in general, because we don't want to be claiming that COVID-19 has been now demonstrated to cause dementia. It might be the case, but we don't know yet. And then we don't know the severity of the disorders. We know that they cause that there is an association with depression. We don't know how severe the depression is, or how severe the anxiety is, for instance, or severe the strokes were. And obviously we don't know what happens to those patients after 6 months. So we need longer follow-up still. So the knowns and the unknowns from this study. Well, what we know is that the diagnosis of COVID-19 is associated with an increased rate of psychiatric and neurological diseases in the 6 months after the illness. This seems to be quite clear from this study. And we also know that the more severely affected patients are at an increased risk of having a subsequent psychiatric or neurological disorder. And that is reflected by the comparison between patients with who were admitted to intensive care compared to those who weren't, for instance. And the third thing that we know is that we probably need to do something about it. There's an increased rate of those diagnoses. We can't just leave those patients untreated. And so there must be something to do. What exactly is part of the unknowns. So the other unknowns is that we don't know. This is a question that we get asked often. We don't know what's causing it. And there's likely to be biological, psychological, and social mechanisms involved, as well as potentially residual confounding. There are things that we unfortunately cannot control for when we do this type of study, such as lifestyle factors, for instance. And we don't know whether that's contributing as well. The biological mechanism might involve the virus itself affecting the brain. It might involve the inflammation affecting the brain. The psychological, I don't need to talk about. Having a diagnosis of COVID is very stressful. And the social mechanism involve things like losing income as a result of having to self-isolate, losing social contact, etc. As I said, we don't know the outcome of the affected patients, so we will need some prospective studies to look those up follow them up for longer time. And as I said, we don't know we know that there must be something to do, but we don't know what to do about them. So this is part of the unknowns. Thank you.
Maxime, thank you so much, and thank you to all three speakers. And I'll hand straight over to Alison Pollock, who's chairing the final session.
Thanks, Fee. So we're on to the third session, prognosis, available treatments and rehabilitation. And I'm delighted to say we've got Melissa Heitman, who's joined us. She's a respiratory physician from UCL and UCLH, but unfortunately, her broadband isn't very good. So though she's joining the panel, we're going to have a pre-record now. So Duncan, if you could take it away, thanks.
Thank you for asking me to speak. My name is Melissa Heitman. I'm a consultant respiratory physician at UCLH. Been asked to talk about the process of setting up a post-COVID assessment clinic. We're the lead provider for North Central London, and our clinic's now evolved to form an integrated post-COVID network in our integrated care system. But we actually started the service back in April 2020 through evolution of a follow-up service for patients going home from our own ED with suspect COVID. We then started accepting GP referrals for people with post-COVID complications and saw patients going home from our own hospital following an admission with COVID. And by the time of the NHS 5-point long COVID plan, we'd had 1,000 appointments in the clinic, and clinic funding started in December. Wave 2 was extremely difficult for all services, but we kept the clinic going, and by the end of March we'd had 2,600 appointments relating to 1,300 individuals. This slide shows the pathway of patient flow through the clinic, and regardless of source of referral, they're seen by the same clinical team and we follow the same approach. In recent months, we've been supporting primary care with development of a screening tool for GPs to use and an EMIS template which generates an electronic referral that's triaged by the borough level single point of access, and patients are either seen in the community post-COVID clinic with MDT support from us, or they come to the clinic if they need more complex diagnostics or input of the wider multi-specialty MDT. And we try to develop a treatment and recovery plan for all patients to be implemented by the community services. So far, we've been able to discharge 48% of patients. The remainder have had ongoing follow-up due to complexity or due to shortage of resource within community services, and hopefully that's going to improve. We had 800 discharges from wave 1 from the hospital and 1,000 from wave 2. We phoned those patients at 6 weeks post-discharge, and from that process, about 500 patients have been brought back for face-to-face review so far from a hospital discharge. We've also seen 500 patients referred by their GP and 200 following referral from the ED safety net service. Tend to see the post-hospital patients sooner after their initial illness at about a 3-month time point, whereas the non-hospitalised patients tend to be referred later, between 6 to even 12 months after symptom onset. The demographics of the non-hospitalised group are different. They tend to be younger, mean age 45 in our cohort, 68% female, 60% white, therefore lower BAME prevalence, which we think is very important to understand. 10% of patients are NHS staff, probably a higher prevalence from wave 1 than hopefully from wave 2. In terms of what we see, that patients have a very wide range of symptoms, but fatigue and breathlessness are dominant symptoms in all cohorts. We do see different phenotypes of symptoms, subclusters, which I think are very important to study further. This is slide shows a visual representation of some of the patterns of illness we see. So well as the dominant symptoms of long COVID, we see subgroups who have autonomic dysfunction, disordered breathing pattern, abnormal exercise physiology. We see quite a high prevalence of psychological morbidity relating to the severity of symptoms that they're experiencing, or the loss of self-image, or the stress of their illness to them and their families. And in short, long COVID is not one thing, and we think of it as a combination of end organ damage and other phenomena. We see evidence that pre-existing comorbidities can be exacerbated by COVID also. And therefore it's a very complex clinical picture. We decide on diagnostics dependent on symptoms, and I've listed the diagnostics that we're finding most useful on this slide. We found it very helpful to have access to a multi-specialty MDT with a core team of respiratory, neurology, cardiology, but input from immunology, rheumatology and haematology has also been very important. We have our therapists present at the MDT, radiology input is very helpful. We're incorporating clinical health psychology into the clinic, and we now have a weekly MDT with our community services, which I think is very high value. In terms of what we found, we've looked at quite a large range of outcome measures as we get a sense of what's going to be most useful. Looking at EQ5L5D, we see non-hospitalised patients have a lower percentage recovery in that subjective score compared to the hospitalised group. We see 30% of patients have MRC breathlessness 3 or above, quite high levels of anxiety and depression in terms of the GAD and PHQ scores. And in all cohorts, a large proportion of patients, over 60%, are unable to work full time at the time of their initial assessment. We found an electronic health record essential for our service. First, it helped us to identify patients efficiently, and right from the first clinic, we defined tools to allow us to collect structured data, which was important for service evaluation and for learning about this new clinical scenario. We've now evolved this to a patient questionnaire for the patient portal, which I think will be very helpful in making most use of clinician time and giving opportunities for patient-initiated follow-up. Implementation of read codes in primary care took a bit longer, and that's been very challenging. Therefore, for demand modelling of the clinic in North Central London, from an ONS statistics, we think we might have 10,000 patients with post-COVID symptoms, and that up to a quarter of those could need assessment in the clinic, therefore 2,000 patients. Now, clearly, to cope with those numbers of patients, we're going to have to work as an integrated care system, and we've been teaming up with other acute providers and the borough community services to try and achieve this, and relying heavily on the virtual MDT model, which I think is very effective. In terms of knowns and unknowns, we feel that all patients with post-COVID complications benefit from early identification of symptoms and good quality advice about managing them. And some patients do need access to multi-specialty and multi-professional support. And achieving equity of access under the approach does require ICS working, just like many other long-term conditions, and we need to develop clear clinical standards, which we're working on in London at the moment. We see that there will be workforce constraints, particularly relating to community therapists, and that's going to require investment and upskilling and skills transference between clinicians to help us support this patient group as effectively as possible. In terms of unknowns, I've mentioned we're still not clear about what capacity each service actually requires. We need to know more about what are the most useful diagnostics and best rehab approaches. We need to know more about the mechanisms underlying the long COVID phenotypes, because that will inform potential treatments. And clearly, we need to know more about what the long-term trajectory of this illness will be. But thank you for listening to me.
Thanks very much indeed, Melissa. So we'll move straight on to Margaret McCartney and Richard Bing, both GPs. Margaret's also with the University of St Andrews, and Richard at the University of Plymouth. Thank you very much.
Hi, thanks so much for having me. So I'm a GP in Glasgow. My full declaration of interest is on whopaysthisdoctor.org. So I'm a GP. I live and work in Glasgow, and obviously the last 6 months or so have been really difficult. The last year and a half have been really difficult. We're dealing with people who have had COVID-19, people who've been bereaved by COVID-19, the huge consequences of social inequalities on our population, people who have been suffering from immense economic and emotional distress, people who have perhaps been working somewhere where there's been a cluster of COVID-19 cases, have brought that home, and a parent or a sibling has died. So there's a huge amount of stress and pressure on people just now, and lots of stories coming through of long COVID as well, which have to be taken really seriously. And I think also we have to be placed into context. And I'm really here to try and offer a bit of contextual information and perspective from a primary care point of view. And it's worth remembering that general practice was in crisis before this awful pandemic. And of course, now that secondary care are not able to do a lot of things that they were doing beforehand, a lot of that pressure has come back into primary care. So we're dealing with a huge amount of uncertainty, both for now and for the future. And something I wanted to sort of bring to the table is that general practice has got long experience of dealing with people after they've been discharged from hospital. After they've been discharged from hospital and they're still symptomatic, and can be very symptomatic for a very long time, with things that we probably think of as common or garden illnesses, such as community-acquired pneumonia. And over the last 6 months or so, I've been looking back into the literature about what we know about usual recovery patterns. What's also alarming about this study is they included any older adult as being anyone over 50, which I thought was a bit mean. But this study, for example, finds that people with COPD and who had had a community-acquired pneumonia, half of them were still symptomatic at 52 days, having a worse health status than they did before they had their community-acquired pneumonia. And that, of course, means at 50, the half of people are still symptomatic well after that. And many of the studies around about this time really ran out at 90 days and really stopped following up people by then. There have been a few other studies looking at people with normal, I say normal, but typical community-acquired pneumonias, that happened without people going into hospital, without having had any further investigation in there. And still by day 180, there is a significant amount of adults who are still feeling that their wellbeing score, which takes account of physical and mental health, have not returned to normal. And again, this is not something that you might find in many textbooks, but it's certainly what you find in the community when people have been really unwell and who are taking a time to recover. You know, serious illness does affect the body and takes a long time for people to get better. At the same time, we've had lots of headlines, lots of stories about multi-organ impairment in low-risk people in the community who didn't go into hospital and who have been scanned, and lots of inflammation has basically been found. And I think people understandably found this very alarming, and I can see why people would have found that alarming. It does sound very dramatic, but what I'm not sure about is what it actually means. And when we look back at, for example, what we know about influenza and what your seasonal influenza virus does to the human body, well, it can affect just about anywhere. And what I struggle to know is how to put the findings from these scans of people who have had COVID-19 into the perspective of what do we know about the human body and how it responds to serious infection and how people recover thereafter. I've got a long-standing interest in overdiagnosis and overtreatment. And of course, I do get concerned when we're doing lots of scans when we don't really know what a normal recovery would look like and what the prognostic implication of any of these findings might be. There is a risk of unintended consequences, I think. It is with extremely good intentions that people without any positive test at all are felt to are not wanted to be excluded from any subsequent interventions for patients. I can completely understand that, but it does mean there is a risk of unintended consequences and people being given a diagnosis which they didn't have and therefore may not benefit from any future intervention. So there is a concern there. I've also seen a lot of people suggesting many different investigations and self-monitoring, but again, I am unclear whether that will actually help people and whether or not that will contribute towards the burden of illness. We don't have good comparator data. You know, do we need this for other illnesses? Do we actually have good data that tells us that this is helpful and useful for people? For some people it may be, for some people it may well not be. I'm concerned about us, lots of different clinics doing different things. I can see people are working with the very best of intentions and extremely hard to try and help people, but there is a risk, I think, of lots of different clinics doing different things and giving quite mixed messages to the public. And I do wonder about whether it's a good idea to be running so many new clinics out with formalised trial settings. We've heard earlier from Joe House about wanting to have a treatment, and I think that really patients and researchers need to be working really closely here to try and work out what those treatments are, because at this time I'm not sure if we know what the best treatments really are. And I suppose this feeds into my concern that we're really not researching non-drug interventions well enough. We are the leaders in the world for doing drug intervention studies, but it seems to me we've got a long way to go before we get up to speed with non-drug treatments. So in terms of what this means, I think we need to get to evidence-based but also personalised care. I think it's really helpful to know what happens to not healthy controls, although they are obviously really important, but individuals who've been unwell with other pathologies and what we know about their scans and their blood inflammation markers and what our experience is of how well people recover from other serious insults to the human body. Clearly, COVID-19 is not influenza, but I think we can learn from the human experience of serious illness. And so I really would call upon the research and patient community to really be working together here to identify what the big questions are in terms of treatments and to try and push forward for that. And what's really astonishing to me is the amount of research that has not been done in recovery from serious illness. And I do feel as though there's a light being shone on how little the less glamorous areas perhaps of medicine have had in terms of investment over the last few years. And I'll hand over to Richard now.
Thank you very much, Margaret, for that introduction. And so, yes, I'm Richard Bing. I'm a general practitioner in Plymouth and professor in primary care research. And my, in terms of disclosures, as well as having that on the web, I have also suffered from a chronic fatigue after Ramsay Hunt about 20 years ago and made a slow and painful recovery from that, and perhaps know something about what it's like to suffer from this. it was really hard to try and monitor yourself and know when it was right to push further and then to slowly rehabilitate. But thinking of us as a GP and as a researcher who specializes in complex interventions for complex needs and formative evaluations and trials of clinical and organizational interventions, I thought that one of the first things to be clear about is the unknowns as a clinician and patient when they meet. We have symptoms which are manifest to the patient: cognitive, fatigue, breathlessness. But underlying that, we have the organ dysfunction, the pathophysiology, which in these kind of conditions is generally unknown. And I'm skeptical, like Margaret, as to whether the investigations tell us a lot about that. They might tell us about specific organ damage, but I think they're unlikely to tell us very much about the psychoimmunoneuroendocrine type problems that may well be happening in variable ways for these patients in a similar way to CFS-ME. We're also unlikely, when we meet people, to know what path of recovery they're on. I think the ONS data was interesting, and I hope I'm not interpreting that, and the Cerulli trial, or a study that seems to show a pretty good recovery for most people over time. So although we're estimating 1 million at 4 weeks, by a year it's, as described, quite a lot less. So there's also the fluctuation over time. We don't know where people are on in that pathway. We're also unclear about how this relates to any underlying problems they may have. And I think if we go back to long-term conditions, some people have other long-term conditions that we're clear about. We may be unclear as to whether there is a predisposition for this problem. We know the epidemiology tells us within the whole spectrum of CFS-ME that adverse childhood events are very important, as well as potential viral etiology. So we potentially have a combination of the two, and I'm not sure that that's been really raised as a potential issue. But certainly, when I think about all the patients that we look after, many of them have problems of fatigue and pain and distress and cognitive impairment that is primarily related to adverse childhood events. So what I'm saying is that this is more of the same. This is what we deal with. This is uncertainty. This is complex things where what patients want is a coherent episode of care. They want to be believed, they want expertise, and they probably want professional friends, that people have described that in some research. They need to have access, they need to have trust and engagement and good treatment. We don't know what treatments to give people, so we're only guessing. So we have physical rehabilitation, potentially. Is it pacing? Is it some kind of, and I really liked Elaine Maxwell's description of the kind of combination of pacing and graded exercise as a sensible way forward, very individualized.
Richard, I'm going to have to ask you to.
So my big question then is, I was interested in setting up the possibility that really this should be a question between general practice care versus multidisciplinary care, both of which have their problems: long waiting lists and bewilderment and MDT, and long and problems of capacity in general practice. But my choice of research study design is actually to do iterative formative evaluation with all the clinics joining together and gathering data and using qualitative feedback, slowly and gradually working out the patterns and systems of care that we need to put in place clinically and organizationally. Thank you.
Thank you very much, Richard and Margaret. That was great. So now we move on to Liz Whitaker, who's at Imperial, and she's going to discuss the very important issue of children, which is timely given all the focus on childhood vaccination. Liz, thank you very thank you very much for doing this.
No problem. Alison, thanks very much for inviting me to talk. So I'm a PEDS ID consultant at Mary's, and I got involved in COVID right at the beginning, and have been describing the kind of post-COVID phenomenon in children, which has largely in our experience been around PIMS. And so just to think about how has COVID affected children, the really good news is that actually the predominant thing for children is that they have remained well or experienced very mild disease and haven't been hospitalized, and certainly haven't experienced many deaths in our pediatric cohort, which is really good. A very tiny proportion of children have experienced this post-infectious inflammatory syndrome known as PIMS TS, where they get very hot and red and feverish, and some of them develop cardiac dysfunction. And I guess what we don't know is what proportion of children are experiencing persistent symptoms after having their asymptomatic or mild COVID disease. Certainly from this website, which is Long COVID Kids UK, which is a support group for parents of children who are experiencing symptoms. They describe a myriad of symptoms, much like adults are experiencing, and I think quite a lot of gastro symptoms, headaches, fatigue, joint pains, rashes, sore throats, etc. And they report the most frequently reported changes are in energy levels, mood, sleep and appetite, and that these are the things that are affecting day-to-day living for the children that they look after predominantly. There is very limited data on this in children, and certainly from talking to colleagues across the country and internationally, we aren't seeing many children who are presenting to healthcare settings with concerning persistent symptoms, whether that's because they're struggling to access healthcare or whether because the numbers are quite small, I think is something we really need to explore further. But certainly the very severe organ damage that I think is associated with severe COVID disease, unsurprisingly, we're not seeing, and thankfully we're not seeing, because children don't experience severe disease. So what this data here from the ONS shows that at 5 weeks in children under the age of 10, we're seeing about 9% of children and about 13% of adolescents are experiencing some of these common symptoms that they were asked about on a survey. And in blue, it's patients with a known COVID positive test, in green without. And then by 12 weeks, those numbers have dropped a little bit to 7 and 8%. So already improving by the 12-week stage. And we really don't have very good data. This is survey data, and it's really hard to know without robust evidence base or with good healthcare data to know how large a problem this is across the population. And children have suffered really greatly from the indirect impact of COVID-19 on their health, because schools have been closed, because there's a lot of parental anxiety, there have been a lack of access to normal routines, lots of increased screen time, and all of these factors that have been picked up in this paper here are impacting both their mental health and their physical health without experiencing any COVID illness at all. And even the young people, so the young people I see in my clinic who've had PIMS or who've been unwell with COVID are really saying, what am I going to tell my friends? And they really feel a stigma attached to having had a coronavirus infection. And they've been really vilified in the media. And I think our young people deserve more respect, because they listen to the news and they watch the television and they read the newspapers, and they know that people are saying, oh, schools are driving the infection, and they're dirty places to be, and they're not safe to go, and they're passing it on to their grandparents. And I think this is a really poor framework for young people to feel that everything is their fault. And as an adolescent, the world centers around you, so everything you hear belongs to you. And we just need to be a little bit careful as the adults and the media around them not to frame the COVID pandemic as being a pediatric problem, when actually they're the group who are least likely to have it. And just on the topic of vaccines, because this comes up as a question a lot, what is the personal benefit to a child of having a COVID-19 vaccine? I've told you that the disease is far milder. And so there's a really different discussion about the risk benefit of giving a vaccine. We really need to know more about safety. We need to know more about efficaciousness. So we know, because they have a different disease phenotype, that they respond differently to the virus in terms of how unwell they become. And it may be that they respond differently to the vaccine. It's a really key that we do trials, and we started off doing trials in February, initially with the AstraZeneca vaccine, and there are plans, of course, to do the Pfizer and Moderna, Johnson & Johnson vaccine trials in young people as well, starting off at lower doses in case children have different reactions, and measuring their effective immune responses. These trials have actually been put on hold a little bit at the moment because of the recent concerns about vaccine-induced thrombocytopenia, thrombotic events, whilst we gather more information. So I think it'll be a little bit of time before we have that data. And again, which we won't pick up in the trials because they're likely to be rare, is we don't know if there are a risk of rare events like a vaccine-induced inflammatory response. But other children may benefit from vaccination sooner. And so these things need to be taken into account. There may be that adolescents might be a group who, for example, if transmission is an issue, we find that we're having to close and open schools, which we know is so bad for young people, that risk benefit switches to saying that maybe it is beneficial to vaccinate adolescents to get them back into school, or for those children with complex health needs. But I think just that is a really difficult question. And at the moment, we don't have enough data on these facts, and also on how big a problem persistent or post-COVID syndromes are in children, to roll out a vaccine program with the data we have. So what are the knowns and unknowns? We know that it's rare for children to get this severe post-infectious inflammatory syndrome. We know that children are experiencing post-COVID symptoms in a slightly different way to adults, much more fatigue-related. And we also know that most children remain well. And so what are the unknowns? We don't know what the immunopathogenesis is of this PIMS condition, and there are studies looking at that. We don't know the prevalence or the pathogenesis of post-COVID syndrome in children and young people, and we don't have a case definition. And I don't think it's right to extrapolate from adults who have clearly had a very different disease phenotype to assume that the post-COVID disease phenotype in children will be the same. So we need to come up with something that is specific for children. And just in terms of the vaccine, we don't know about the safety and efficacy. So there is a study that's just gained ethical approval, and we've started to invite the first participants. This is a national study involving many centres across the country. It's focusing on the adolescents because it's based around a PhD study of young people who've taken part in COVID studies already. So we know already that we have a group of 3,000 children who are known to have a COVID test positive and 3,000 who are known to be COVID negative. And they're going to be contacted to complete questionnaires and health assessments for a 2-year period. And hopefully this is going to give us information about the prevalence of persistent symptoms in children. We're applying for further funding through the latest UK call to try and incorporate some immunopathogenesis into the study, using 2 studies that are already ongoing through Imperial, Prevail and Diamonds. And in addition to that, with the Bristol team and across the country, to look at what interventions work best for children. And alongside that, and Melissa talked beautifully about the amazing service at UCL for adults, we're trying to design an appropriate service for children and young people. And key to that is gathering data on throughout about every patient who presents to healthcare settings, and having a standardized approach, because I agree with Margaret that that's really a key. And also we're trying to involve local paediatric services to make sure that everybody who has access needs it, that it's a multidisciplinary problem and family-based, because I think that, not surprisingly, parents are really struggling in seeing their children experiencing these post-COVID symptoms, and they need support in their own right as well. And so I'm not going to run into this, but we've thought quite carefully that we want children to be able to access this care from school, quite crucially. I think teachers and school nurses can recognise when young people are involved with are struggling, from CAMS and thinking about pre-morbid conditions which are exacerbated for children who haven't been hospitalised and those who have, coming through primary care and then paediatrics, and having specialist services who work very closely with other professionals to make sure that each and every child who needs support can access it. And I really hear the talk about equity for children who haven't got long COVID but are experiencing persistent symptoms for other reasons. We really want everyone to have the ability to receive support to get on with life and enjoy it in a normal way. So just in summary, children experience less severe disease than adults. It's crucial to support the recovery for those who do experience significant disease. And we have an urgent need for research into these syndromes and persistent symptoms in children, because let's face it, they're at the beginning of their life. They've had a really tough year and they deserve to be put first. And I'm going to stop. I was going to add some things about neuroinflammation, but I know we're running out of time. Thanks.
Liz, thanks very much. That was fantastic. Very powerful advocacy for children that we need to really seriously think about. So I'm going to go next and last to squadron leader Rob Barker-Davis, who's working at Headley Court in the Academic Department of Medical Rehabilitation. And he's going to be talking about exercise and graded exercise and when it is and isn't appropriate. Thanks, Rob.
Many thanks for the introduction. Just to say that we've moved from Headley Court now to Stanford Hall, the Defence Medical Rehabilitation Centre in the East Midlands. I'm a postdoctoral researcher and registrar in rehabilitation medicine and both sport and exercise medicine. I came back into the training system after working for a GP for the Armed Forces for a couple of years. I'm going to frame what we knew coming into this pandemic, specifically with regards to the relationship between exercise and viral illness. Touch on how that interplays with our role in delivering occupationally focused healthcare in defence medical services, and where that's led us in terms of making recommendations and designing clinical services, and the unknowns and the focus for our research. We look after mostly, but not entirely, a young active population employed to undertake physically demanding roles. So regardless of how you look at the role of exercise in viral illness, be it something to avoid for hopefully a short period of time, or a symptom modifier, a rehabilitative therapy, a risk factor for transmission, or any other angle one can think of, our main effort was always going to be to return our personnel to be fit for the roles that they're trained to deliver. And how to deliver this safely and potentially at scale, therefore became a major concern. Of course, COVID-19 is a new disease. So early on, the focus was on sharing what we knew about related pathologies and forming consensus guidance. And we did that with the Stanford Hall consensus statement published in the BJSM in May last year on the slide here. And in that, we looked at mostly data from SARS and MERS, and to a lesser extent flu. So to acknowledge the unknowns, much of those recommendations were based on level 4 or 5 evidence, or extrapolated from animal-based research. We found evidence highlighting the harmful effects of physical inactivity and obesity on the immune response, but also that prolonged and vigorous exercise can result in increased symptoms. For example, many people will be familiar with the neck check, which athletes have used for decades to decide whether or not to train with what they hope are transient viral symptoms. The idea being that if the symptoms are below the neck, to rest, and if they're above the neck, to continue with caution. And we really couldn't find any good evidence for this. We also have had experience of treating other post-viral fatigue syndromes and patients with myocarditis in the past. And we therefore recommended a cautious, stratified approach to exercise following acute COVID infection. We recommended longer rest periods prior to return to training than widely accepted previously, being 2 to 3 weeks as opposed to 7 to 10 days. We recommended starting with simply limiting sedentary periods, low-level stretching, light muscle strengthening activity before the more targeted cardiovascular sessions, but absolutely crucially on an individualized basis with ongoing review. And I'll just expand on that a little. We discussed in, I think you can see the slide now, the steering group for the NIHR Living with COVID themed review, the term graded exercise therapy. We were aware of the discussion surrounding the 2007 NICE guidance for chronic fatigue syndrome, and keen to stress that we were not advocating fixed increments in activity or assuming a linear resolution of symptoms. However, mindful of the great number of benefits associated with physical activity, if you take, for example, Quigley's scoping review in HIV that shows that physical activity can improve cognitive function, there's a need to harness these intended benefits of exercise, but in a safe way. And so I feel it may be helpful to symptom titrated physical activity as opposed to graded exercise therapy. Physical activity as opposed to exercise, in that we need to take into account a more holistic view of all of a patient's activities through daily life, rather than prescribing putting on sports kit and gym-based activities. So it's things like incorporating that walk to the bus stop into the equation. And when you think about the practicalities of that, you quickly realize a one-size-fits-all starting point is unrealistic. We mustn't shirk away from the key training principle of progression, but it needs to be symptom titrated, i.e. we need to understand the effect of the change we've made before proceeding. Otherwise, we risk a stepwise deterioration. If that's where patients are left with limited support or unrealistic expectations about the speed of their recovery and progress, perhaps from an unsympathetic workplace, then things can really deteriorate. And we're potentially seeing some data that shows that. We looked at our first 155 patients to be referred from armed forces GPs for us at the tertiary rehab centre at DMRC. And we found at that initial video teleconference we had with them that those who'd not received laboratory confirmation of their diagnosis presented later with increased mood and anxiety disturbances, despite no significant difference in their acute symptoms. And I'd like to just link that back to the very rich description that Joe House gave earlier about the need to be believed and be able to access services. We've held patient forums, education sessions, occupational therapy workshops, etc., as part of our residential course for post-COVID rehab at Stanford Hall. And one thing that struck me is that our patient group, at least, is supporting patients in understanding pacing and the boom-bust cycles isn't going to be achieved in one session. However, it's vital to get that message across and support the people around those patients. So the family, the friends, the work colleagues, you've got a group of people in our cohort, at least, who've never had to pace before, a lot of them, people who've often been functioning at a higher level than those around them and who outwardly don't look unwell. And one way I've described it, and the parallels are interesting here, potentially from a pathoetiological level, is in relation to overtraining syndrome. When athletes train too hard or with inadequate rest, they suffer from overtraining syndrome, which has symptoms similar to post-COVID, fatigue, depression, tachycardia, insomnia, irritability, and so on. And there are a number of suggestions about the cause of overtraining syndrome, and that includes autonomic dysregulation, increased inflammatory cytokines, and dysregulation of the hypothalamus. And all these are mechanisms that have been proposed for the post-COVID syndromes. So I think I've described our general principles for safe return to exercise, but when do we need to investigate further? And there are many unknowns here, and I think my unknowns slide very much could mirror the points that Melissa Heitman just made a few moments ago. One of the challenges, and again our own data supports this, is that the acute symptoms do not appear to predict the symptoms at a median of 3 months follow-up. Clearly we need to use the skills that we already have in picking up significant pathology, but also at the moment in defence we're asking our GPs to refer patients who required supportive ventilation and or chest pain and ECG changes and or desaturation on a simple Harvard step test or 6-minute walk test to us. But another unknown is, what is the optimal pathway for onward referral? I think it's likely to depend on the underlying pathophysiology, and as Elaine, Maxwell and Simone Benatt had described earlier in this webinar, we're starting to see distinct symptom clusters. And for example, the patients that we've got with the dysfunctional breathing patterns and the dysautonomia, we've looked at using cardiopulmonary exercise testing as a functional test that can distinguish those pathologies from respiratory or cardiovascular limitations that require further investigations such as CT, CTPA, and cardiac MRI. And we're conducting further research into the sensitivity and specificity of cardiopulmonary exercise testing and hope to be able to publish on that very soon. A normal CPET test, depending on this accruing data, has the potential to exclude significant structural cardiopulmonary pathology. Another key question, assuming we can accurately diagnose these syndromes, is what is the likely prognosis? And greater data and clarity here, we hope, would be widely accepted, and as Joe was saying earlier, influence patient and employers' expectations that allows the right time and space for healthcare to be delivered to support better outcomes. And that's the focus of our ongoing study, the M-COVID study, which we're conducting investigations I just mentioned in distinct groups of hospitalized patients, community-based recovered patients, and community-based ongoing symptoms. And I agree then that doesn't necessarily mean that they had a mild illness, and comparing those to unaffected controls over 12 months. I think I've just about had my time, but I'd like to briefly thank my colleagues here who are central to this ongoing work.
Rob, that's really useful, because exercise, of course, is quite contentious and heavily debated. We're going to move now to Phil, I think. So Phil, it's over to you for questions, and Nikki.
Thank you very much indeed. Gosh, what an extraordinary session that's been. I should declare an interest. For the last decade, I've been working as an associate specialist in the Paediatric Chronic Fatigue Service, which is based at the Royal United Hospital in Bath and has research links with the University of Bristol. So Esther Crawley, my consultant, will be involved in the clock study with Liz. We're starting long COVID treatment. But interestingly, the patients I've seen over the years since the pandemic started with perhaps post-coronavirus fatigue have not been that different in the paediatric service from those I normally see with ME/CFS. Professor Crawley came up with this brilliant idea when I started the service that the best way to understand the condition we don't really understand is to have 90-minute initial consultations. I think probably almost unheard of in the NHS. And although these poor young kids have been really through the mill often, it's the most rewarding job I've ever done, because you have a chance to truly acknowledge what they've been through, to understand and to involve them in the decision making. And my experience over a decade is it is something that has to be individualized. You have to involve the whole family, and the longer initial concentration seems to build up that relationship. So that's my experience. Probably young people possibly have a better recovery rate. Probably at least a third of our young people make a complete recovery. Some of them sort of reach a plateau and stay there. And some of them recover and then have really disabling flare-ups later on. And it's impossible to say early on which category a young person will fit into. But the trick is to involve them as much as possible in their recovery. And the other trick, really important, is to stabilize their sleep. We haven't talked about sleep at all in this, but I would imagine in post-COVID syndromes, as well as in ME chronic fatigue syndrome, stabilizing sleep is absolutely vital to recovery. So that's a little bit of extra I have to add. Nikki Nabavi, we never introduce you. We sit there and it goes over to Nikki. You're as a medical student and a BMJ scholar, is that right?
Yes, yeah, that's right.
So what are you going to do with your one wild and precious life? Have you decided?
I'm not 100% sure yet. I think potentially psychiatry. Okay. But I'm really enjoying my year at the BMJ, so my option.
Well, I need you, and apologies for not introducing you earlier.
Yeah, that's so fine.
Together with your question. So give us the first question and who it's for.
Yes, of course. So the first question is for the first panel. And the question is, how much of post-COVID is the onset of entirely new symptoms and conditions in comparison to them being exacerbation of pre-existing symptoms or conditions from COVID?
So this is interesting. Joe and Nikki, probably can we ask you first, because you're the one with the lived experience of this, and I was very moved by your presentations. Can Joe and Nikki tell us, in their view, how many of the symptoms that they're getting now were exacerbations of initial symptoms and how many are new ones? Are you there, Joe and Nikki?
Yes, I'm here, thank you. Yeah, mine were, the only pre-existing condition I had was migraine. And actually my migraines got better for the first 6 months of COVID. It was one of the, small pluses. Almost everything else was entirely new, including the heart condition, the arthritis. I had very, very mild asthma, but nowhere near the breathing problems that I had now. And I'd only had that for a year after another viral thing.
Okay. And quickly remind us again of the importance of acknowledgement. It's extraordinary, isn't it? I often find with young people, if you tell them this is a real condition, you're not making it up. It's what you've been through and coped with, and suddenly. Yeah,
actually, funnily enough, my son, amongst his multiple medical conditions, also has ME, and is actually he's 18 now, so he's just transitioning out of your clinic. And yeah, actually speaking, but what you said about giving people the time, we hear that time and time again when people do actually get to the long COVID clinics, the time to discuss and ask questions. My GP's been fantastic personally. I've had really good GP, but they can't know, they're very constrained. So when you get to the long COVID clinic and they know more and you can ask more, even if they don't have much they can offer in the way of help, everyone just talks about it being a watershed moment, that being able to talk to somebody who believes you at length.
Thank you, Jo. Elaine, what's the research shown about how many people have, when they get long COVID, are they exacerbations of their initial infection symptoms, or is they getting new symptoms on top of that?
So there's two answers to that. There's a lot of people who are getting entirely new symptoms who haven't been ill before, even though it seems to be more prevalent in people with previous ill health. But there was an interesting study in Paris by Dominique Sanin-Serron that looked at this fluctuating corona coaster and found that a lot of people get new symptoms during their long COVID journey. So they will have symptoms, they will get better, they think they're recovered, then they relapse with different symptoms to what they had with their initial infection. So it's very hard to say what the symptoms of long COVID are, and that's part of the problem.
It's difficult, and I've always thought that, ME is hard for some people to understand, but chronic fatigue syndrome is poorly named because people get far more than just that. They can get dizziness, headaches, nausea, autonomic dysfunction, quite severe pain, and yet they think of it all about as fatigue. So it's important we find some way that embraces all that multitude of symptoms.
And if I can just add to that, one of the problems with looking at the prevalence of long COVID is, for some people who had a mild initial infection and then had a period of feeling well, and then they get a totally different symptom, they really don't associate that with long COVID, so they're not accessing the support.
Nikki, you wanted to add yours, but welcome. Nice to see you, Nikki. Thanks for taking the time to join us. What did you want to say?
Yes, thank you for having me. I was here as Jo's support, as she explained, because with long COVID, you never know how you're going to feel quite often from one day to the next. I originally got symptoms that were assumed to be COVID in February last year, and I've had symptoms ever since. My only previous condition was mild asthma. But over the last year, I've had a whole range of things: tachycardia, blinding headaches, rashes, crippling joint pain, the breathlessness. I can brush my hair and my heart rate can go up to 166 beats a minute. Luckily, I'm back to doing some exercise. I can walk for half an hour or so fairly gently, but I still get all these symptoms coming and going. And I just wanted to say that with long COVID, people are finding different conditions coming up a long way into their progress of this condition. And we know people who had scans, tests early on or within the first 6 months and it didn't show anything. And now a year or so later, people are finally being diagnosed with myocarditis, multiple lung emboli, and all sorts of things that aren't showing up on the initial basic tests are being picked up by more in-depth tests. So people need to be listened to. People with long COVID should be monitored all the way throughout their illness to check that potentially life-threatening conditions are picked up.
Thank you, Nikki. Can I just ask you, out of personal curiosity, how's your sleep at the moment? Do you have a regular sleep pattern, or do you wake up all over the place and wake up feeling exhausted?
Yeah, pretty much all over the place. Funnily enough, and I noticed in the questions, some people had asked about potential effects of the vaccine on people with long COVID. Some people have said that it's helped their symptoms. Me, overall, it's made me worse. It exacerbated my worst remaining symptoms. However, one thing that has improved for me since I had the vaccine is my sleep. I'm actually sleeping better. I still wake up feeling ill, but the actual quality of my sleep has certainly improved.
Thank you, Nikki. I could listen to you for 90 minutes, but sadly, I have other people to talk to, but thank you very much. And if there's another thing for you to come in on, please join in. Nikki, who are we going to next?
Let's move on to panel 2 for now. So the next question is long COVID really more common in women, or is it rather that men are more likely to die with COVID and are therefore not around to get it?
Oh, contentious question. Who's going to take that one first? Someone brave.
I can pick that one up from the perspective of our study. So what we've seen is about 1.7% of the population with long COVID. That's about 1.9% of women and 1.5% of men. So it's more prevalent amongst women than men. That's what our representative study shows. What we've seen with mortality is a different pattern. So there's a really steep age gradient with mortality, and it starts at about 70, 75 and is very, very steep. And those are the people that would have been dying in numbers throughout the pandemic. Unfortunately, the long COVID tends to be in the working age population, so it is two different groups. It isn't a case that you know, it's equal numbers, but higher mortality rates amongst men explain the differential. It's more complex than that, and we're working on exactly what the difference is.
Do you think there's a possibility that men and some ethnic minority groups are more reluctant to come forward or to acknowledge their symptoms because of some stigma associated to it?
It's possible, but the differences are significant. So we see that sometimes with studies. It doesn't look like that at the moment, but we're gathering a larger sample all the time, and we'll be able to discount that if that is a factor.
Interesting. And I'm old enough to remember with shame when we used to label ME/CFS as yuppie flu, when it was nothing of the sort. It's in fact common in working populations. It's just middle-class educated people are more likely to come forward for help and more likely to know how to access the system. So there's often
and we've seen that as well with the long COVID prevalence. There's a higher proportion in the most deprived sort of quintile, 20% of areas of the population. So that's based on the index of multiple deprivation. It's an area-based thing, but we're seeing more from the most deprived 20% than the least deprived.
Okay. Simone, are you still here from Italy? Do we still?
Yes, I'm here. Yes.
Would you like to comment on that? Do you have the same differences between women and men in Italy?
We have observed, as I showed you, a slight prevalence of these symptoms in females, actually. But I cannot give you population data. Our sample is very hospital-centered, as I told you.
Because it hit you a bit earlier in Italy, can you offer us any hope? Have you had people who seem to be really severely affected with post-COVID or long COVID symptoms who have now made a complete recovery? Have you seen anyone in those categories?
I cannot give you numbers. I have to say that here in Italy, it doesn't seem to be perceived by the public opinion as a huge problem, long COVID. We don't hear a lot of talking about that here. I don't know why, but it's not probably such a big deal as it is apparently in the UK.
And you don't know why. Speculate why it's less of a problem in
No, I can't. It's too early to say.
Okay,
I don't know.
Thank you. Okay, Nikki, let's move on to the next question.
Okay, so health systems seem much likelier to be aware of post-COVID issues with patients who are hospitalised during the acute phase of their infection. Are they as assiduous about identifying post-COVID syndrome amongst patients whose illness never led to hospitalisation?
Who are we asking this to, Nikki? Is it still the second group or the third?
This is now panel 3.
Panel 3, that's a really interesting point. So Joe talked about prejudice, how people aren't taken seriously, particularly if they didn't have a positive test or weren't hospitalised. Do you think that's true? Margaret, where are you? You can answer that one because that's a tricky one.
Yeah, so I'm here. It is a tricky one. You're absolutely right.
How are you, Margaret, by the way?
Tired. Yeah, so I think it's all really difficult because it's really easy for doctors to do more and more tests and to do tests and tests and tests. And general practice is, you know, we're working differently just now. It's really difficult. Again, can I emphasise the tragic consequences of health inequalities that we're seeing just now, which have been devastating to many people in our community. And I completely echo what Liz was saying about the impact on our young people as well. So there's a huge amount of distress out there. And I suppose what you're really asking is, are we actively going to find people who have had COVID to find out how they're getting on? So whenever we've had a patient test positive for COVID at one of the centres in the practice, we have made efforts to contact them almost always, unless it's someone who we know is fit and well and has already been receiving care. And I think we have phoned the vast majority of people with a positive test to find out how they are and what we can do, and to remind them that we're there. And you know, I will do what I can, you know, but you know, it's hard to know what the best thing is to do when we don't know what the benefit is of any further intervention on people who are otherwise recovering in a way that they think is appropriate. We are there and we can speak to people, you know, as they wish, but in terms of actively going to find people in order to offer them an intervention of unknown benefit, I don't know if that's helpful or appropriate. Because every time you're putting resources into one area of the health service, you're effectively taking away a resource from somewhere else. And I just want to emphasise again, we're needing research here to help us know what the best thing is to do with people who've got symptoms. And it just seems to me just now that things are so fragmented. People are doing their best, they're trying to offer something helpful, absolutely, but do we really know it's helpful? We've got things wrong so often in medicine when we haven't started off in a position of stating our uncertainty, and surely that's what this session should really be all about.
Okay, Joe's got a hand up, and Elaine. So Joe, would you like to go first, and then Elaine?
Yeah, thanks for coming back to me, Phil. And I know what Margaret's saying, and I know there's this sort of risk of going through and having lots of tests and they come back negative, and it can be, you know, quite disheartening. But I have to say there is basic things we know from SARS and MERS and MECFS about, you know, pacing and about not pushing through. There is some really good basic advice that we could give people about resting, getting sleep in order, even if there's not a treatment and even if we don't know what's going on biologically. It just comes back again to just not being able to emphasize enough the importance of people of being heard and having a chance to talk through with someone who has a good broad understanding and being able to ask questions. I had another point, but with my brain fog. But also, you know, and I think you talked about the risk of unintended consequences and over treatment, but I think that the thing is, if someone comes forward with symptoms, I think there's more of a risk of excluding them in case it isn't COVID than including someone who's got symptoms that even if they aren't through COVID, they still need treatment anyway. And then also blood testing to rule out the really, you know, really dangerous pathologies of things like clots that seem to not just come up in the acute phase, but come up at any time, and heart conditions that you should then push through with exercise.
Yeah, thanks for that, Joe. Elaine, what did you want to add?
Well, I think this, I really sympathise with Margaret. GPs are really busy and they can't do everything, but I think this illustrates that when we first started looking at long COVID, we were really looking at hospitalised populations, and that was relatively easy to do because we knew how many people had been in hospital. Last year in the UK, community testing was suspended for large parts of the year. So the 4.4 million who tested positive is probably only half of the total number of people who've had it. So if you're trying to design a research study, where do you go to look for the people who didn't test positive? You don't know what the denominator is. So the prevalence may be lower because we're using the wrong denominator.
That's a good point. Margaret, you wanted to come back? Thanks, Elaine.
Yeah, sorry, it was just about the idea about tests and when they're appropriate or not to do. You know, there is a very wide spectrum of people that we see in general practice. And one of the things that I think sometimes happens is that there isn't a broad-based representation sometimes of people who have got symptoms within the community. It's hard to find people who, for whatever reason, are not engaging with whatever groups or online. I mean, lots of people don't have a smartphone, they don't have any online access. And I think I can understand people are wanting a diagnosis, they're wanting to get tests done. I personally think it can be helpful to do some tests sometimes, but doctors should learn from the fact that we have been throwing tests around for decades and often finding that they're not helpful, they're not useful. And unless we're doing things thoughtfully and with an evidence base behind us, it is completely possible to do more harm than good, all while having the very best of intentions. So I think there just has to be much more research behind this and much more acknowledgement of the fact that we don't know the answer to a lot of things just now, and we have to share that uncertainty rather than saying that we're convinced that we know what we're doing. I mean, I've been a GP for a long time and I would like to think I'm fairly competent in many things, but we have to admit some humility here and say, actually, you know, there's lots of things that we just simply do not know, and it's not, I don't think it's good enough to say that we should immediately transfer all our knowledge from other diseases into this, but equally we have to acknowledge the fact that we understand what kinds of insults the human body can recover from and how it does that.
Melissa, are you still here with us, Melissa?
Yes, I am here. Can you hear me?
Yes, we can. So nice to see you. Oh, you've got a busy house there. That's even better.
I'm sorry.
That's lovely. Tell us a bit about how. I mean, we know that waiting lists for all sorts of conditions are now at record levels, 4.9 million. You've got lots of people. This illness is like a dirty bomb that can cause multi-system disease that we never predicted. And you're trying to prioritize who gets further investigation and who doesn't. How do you make those decisions clinically? And is it all part of an evaluation, as Margaret says, that will give an evidence base at the end of it?
Yeah, I mean, obviously, this burden on the healthcare system is something that we're really struggling to meet at the moment. But these are patients who are very unwell and they absolutely need care. And they're already, in a sense, causing us challenges, in that many of the patients we see are often having multiple attendances to A&E departments. They're using their GP very heavily. And so it's, you know, how can we most efficiently support them? And I think I agree with Margaret that we don't know what are the right diagnostics at the moment, but we do also quite often see important abnormalities on diagnostics. And obviously some of the symptoms people present with are quite worrying, and it's very important to exclude other causes of those symptoms and make sure that you're confident with your diagnosis. And although people say that, you know, the service that we're trying to sort of develop seems like it might be very expensive, I do think that if you can build a model that delivers integrated care, that's really high value. And we've already seen in North Central London that the bringing together of these long-term condition clinicians has had knock-on benefits for lots of other diseases, because of course we're all the same crew of people that look after our patients with COPD and with heart failure. And we found that actually there are new ways of working in the NHS that can really help to bring specialist expertise out of the hospital and improve the quality of care for a broader range of the population without needing an outpatient appointment. Because absolutely the key thing at the moment is we don't want to bring lots of people to hospital outpatients.
It is interesting. I mean, over the last, 14, 15 months, we've been doing all our consultations for chronic fatigue syndrome, pretty much 95% of them online. And the young people prefer it by and large. They're used to using that medium. They don't want to travel to hospital because they have fatigue, and travel is exhausting for people to find a car space or whatever. But you have to safety net it, because you can't examine the patient physically, but there will be a cohort of patients where video consultations and that remote access, often with faces they've already met before, is actually extremely useful for them, and they would probably choose that in preference to coming up to hospital. Do you think? I think
Phil, it's that combination which I'm sure is right, and you know, Melissa's right that we can learn a lot about how to provide care for complex conditions where we don't quite know what's going on, acknowledging that uncertainty. But I think it's a graded approach. We need to be breaking down the primary-secondary interface and have a graded approach where a lot of people are getting really good support with a coaching approach focused on the symptoms, supporting the cognitive problems, supporting the fatigue, and learning for the individual what makes a difference. But then if you worry, having that access to a consultant or a specialist in a certain area or a diagnostic, have a conversation, get access now, but then get them back into that relational work, which is so important for patients, so that they know they've got someone alongside them working with them. So I would say we need a much more integrated approach. Breaking down and using remote a lot of the time is fine.
On a slightly more personal level, as someone who suffered severe fatigue after Ramsay Hunt, what did you learn on what worked for you? So I
think I went through, I was acutely ill in hospital and could do nothing, lying in your bed, searing headaches, not knowing what was going on. And then you had the lying around phase of just feeling exhausted, and then being encouraged to slowly be part of an exercise regime. I don't think I used either graded exercise or pacing, but I was certainly encouraged to do more slowly, but do it at a very personal level. So I think the advice we've had around that, difference between that is really helpful.
I think of it a bit like a high jump bar, and you allow the young person or the patient to set the bar at the level they want to, and raise the bar little by little when they feel ready to do it, so that they're in control of that. They're never forced to do anything before they feel ready, and they give it a go when they do feel ready.
But I think knowing that recovery is common to most people, and I think we have this problem at the moment where a lot of people are recovering from COVID. They're exhausted at 12 weeks, but most are recovering by a year. Those that are left, it is really a problem, and that's where it's more similar to CFS, I think.
Okay. Nikki, do we have any more questions?
One of the most common questions, which Nikki mentioned earlier, is about the effect of vaccines on patients with long COVID, or if there's any data on that.
Gosh, we haven't got the vaccine experts with us. Has anyone actually looked at it, whether it is... Joe, you presumably got some patients on their response to vaccines. What are the patients saying?
Sorry, I was going to say, obviously it's not a clinical trial or anything, but Gez Medinger, who's a long COVID sufferer but former filmmaker, has been running lots of patient surveys. And he did one of about 500 long COVID patients and how they responded to the vaccine looking 2 weeks post-vaccine, so getting beyond any of the more immediate responses to the vaccine. And he found that about half of the people who responded to the survey didn't have any difference. And of the other half, around about 2/3 felt a little better or a lot better, and around 1/3 felt a little worse or a lot worse. But, that's just a sort of simple survey, not a proper full clinical.
No, that's very helpful. Thank you, Joe. Ben has his hand up, but his microphone off. Do you want to contribute, Ben?
Yes, just a quick point. We do have a vaccination marker on our survey, the COVID infection survey, where we calculate the prevalence of long COVID from. So we should start to be able to analyse that in the next few weeks as the vaccinated cohort increases in amongst that. So and we've also linked vaccination data to primary and secondary care data in order to study exactly that, to see what the multi-organ impairment is, and repeat that study.
Is Liz, thank you for that. Is Liz Whittaker still here? Liz?
Hello.
Hi, Liz. How are you?
Good, thank you. How are you?
Very well, thanks. Tell us a little bit how can we safely resume vaccine trials in children, given that we now have these worries about very rare clotting events in younger people?
Yeah.
Do you think it's possible now to trial these vaccines safely in children?
I think it's going to be really difficult to go back to the AstraZeneca trial, although actually we're really grateful to all the families who took part. There had been quite good recruitment in the last 6 weeks before they were paused, and all of those young people have had a first dose without adverse effects. So I think I think over time we're going to understand a bit more about the process, and we'll be able to perhaps identify prognostic features or blood test results that might be able to predict who's going to be at risk of developing it. And I suspect that that's going to be the way back in. But Pfizer and Moderna, the other types of vaccines, I think that they're paused at the moment in the UK, but they're pushing ahead overseas. And I suspect that's going to be the way forward for children at the moment.
Thanks, Nikki. Any last question, Nikki, or is that our lot?
I can give you another one if you think there's time. Or
what are we doing? Are we gone to 6:15?
We're past 6:15.
Better stop then. Sorry, we could go on. We have to stop. Fiona, do you want to come in at the end, or is Fiona's?
Thank you so much, Phil, and thank you, Nikki, and thank you for fantastic questions from the people listening in, and to all our wonderful speakers and chairs. I hope you'll join us for next one on COVID-19 and mental health. Very best of luck to all of you who are struggling with this very complex and difficult condition, and please keep in touch.